Okay, welcome folks to today's GCI Research Rounds. So as usual, I will just do a bit of housekeeping and introduce our speakers before I pass it over to our speakers for today. So thank you all for joining. Before we get started, I'd just like to acknowledge the traditional unceded territories which I'm joining in from today. So today I'm in downtown Vancouver. So I'm joining in from the territories of the Coast Salish peoples. So specifically, those are the territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And as always, I encourage everyone to spend some time to just think about the territories which you're joining in from today. I know we have a lot of people. One of our speakers is joining from not even in BC. So it takes some time to just think about that a little bit and to reflect on how that impacts you and your work. So just some brief housekeeping. So a reminder to everyone to please keep your microphones on mute during the duration of the presentation. Please feel free to use the chat function if you have any questions, and we will have a Q&A session at the very end. This meeting is being recorded and will be made available on our website afterwards. So without further ado, I'm very happy to introduce our two speakers for today. Today we are introducing Dr. Janice Kwon and Dr. Alicia Tone. So Dr. Janice Kwon is a gyne-oncologist, vice head and professor in the Department of Obstetrics and Gynecology at UBC. She also serves as chair of the Priority and Evaluation Committee at DC Cancer and chair of the National BRCA Collaborative. Her expertise is in hereditary cancer syndromes and conducting cost-effective analysis of testing criteria and risk-reducing interventions. She currently holds a Health Professional Investigator Award from the Michael Smith Foundation for Health Research. Dr. Alicia Tone joined the Ovarian Cancer Canada team as scientific advisor in May 2019 and became the OVCAN project manager the following November. Her deep well of experience in the ovarian cancer field includes a PhD in ovarian cancer biology from the University of Toronto and postdoctoral studies in ovarian cancer genomics at BC Cancer Agency, and then moved on for 7 years as scientific associate in the Division of Gynecology at the Princess Margaret Cancer Center. So we're very excited to have both of these individuals speaking to us today. So I'll pass it over first to Janice and then to have her start us off.
Thank you very much, Stephanie. And I'd like to thank the GCI for the opportunity to present today. I have a few acknowledgements as well. So I would like to acknowledge that I am living and working on the unceded and ancestral lands of the Squamish, Musqueam, and Tsleil-Waututh peoples. Secondly, I'd like to thank my colleague Alicia Tone, who will be co-presenting with me. And finally, I'd like to thank the members of the National BRCA Collaborative, particularly Gina McQuaig and Raymond Kim, who contributed some of the slides for this presentation. And you'll hear more about the BRCA Collaborative during this presentation. My only disclosures are research funding from AstraZeneca Canada for a pilot study in tumor testing in ovarian cancer, BC Cancer, as well as honoraria for a CME event earlier this year. So the objectives of this presentation are to discuss why genetic testing is so important in ovarian cancer, to review some of the challenges to genetic testing, describe some of the initiatives to optimize genetic testing, where does tumor testing fit into all of this, and finally, because genetic testing is the first step in cancer prevention for many individuals, I want to spend a little bit of time talking about the cancer prevention journey, and then you'll hear more about that from Alicia. Why genetic testing in ovarian cancer? We now recognize that up to 20% of all ovarian cancers can be attributed to a hereditary predisposition. And we know that there are a number of clues to a hereditary cancer. There may be multiple people diagnosed with cancer, multiple generations affected. There may be multiple primaries in particular individuals, such as someone diagnosed with both the breast and ovarian cancer. Early age of onset, such as breast cancer diagnosed in one's 30s. And finally, we now recognize that the patient's tumor itself is very informative. We now know that specific histotypes of ovarian cancer, notably high-grade serous carcinoma, are associated with a very significant rate of BRCA mutations. So high-grade serous carcinoma is associated with up to a 20% chance of carrying a BRCA mutation. And so we were the first to publish a cost effectiveness analysis demonstrating that it is cost effective to test women with a high-grade serous ovarian cancer for a BRCA mutation, irrespective of family history, ethnicity, or age. And this has been adopted by many jurisdictions across the country and around the world. Now, why is it important to test ovarian cancer patients? Because the nihilistic perspective is that if they've already been diagnosed with ovarian cancer, then what's the point? Well, there are many reasons why it's important to test ovarian cancer patients. It's important for the patient herself. It helps to explain their current cancer. It may clarify future cancer risks, and it clarifies her family risks. And now there's a very important therapeutic implication of carrying a BRCA mutation. These patients are now eligible for a PARP inhibitor, and you'll hear more about this a little bit later. It's important for the family because it helps to explain their family history, and it clarifies their family risk. It provides them with access to genetic testing and high-risk screening. And finally, they have the opportunity for cancer prevention strategies. They can undergo risk-reducing surgery to avoid the diagnosis of ovarian cancer. The diagnosis of or identification of a BRCA1 or 2 mutation, it's long been recognized that these are associated with very high lifetime risks of breast and ovarian cancer. And so you can see in the first figure, lifetime risk of developing breast cancer is in the range of 70%. And the lifetime risk of developing ovarian cancer is about 40% for BRCA1 and close to 20% for BRCA2. And a woman who is identified as carrying one of these mutations is advised to undergo risk-reducing bilateral salpingo-oophorectomy and consideration of risk-reducing mastectomy. And this is what Angelina Jolie did in 2013 and in 2015. Now, I'm a member of the National BRCA Collaborative. This is a committee comprised of members from 6 stakeholder organizations representing the GOC, medical genetics, nursing, pathology, genetic counselors, and Ovarian Cancer Canada as our patient partner. And our mandate is to improve opportunities or maximize opportunities for genetic testing and ultimately cancer prevention. The National BRCA Collaborative is comprised of these members representing those stakeholder organizations from across the country, and it is a real privilege to work with all of them. And it is, I'm very fortunate to work with Alicia Tone, who's the co-chair of this committee. Our vision has been adopted from an earlier GOC initiative called BRCA Tot, or BRCA Testing to Treatment. And the vision was no woman left behind with respect to genetic testing. The goals were to recommend and offer BRCA testing to all women with high-grade pelvic epithelial malignancy. And this genetic testing is considered part of a patient's family's cancer prevention strategy. And we've expanded the vision for our collaborative in recommending tumor testing to all women with a high-grade serous carcinoma. Now, this was the genetic testing landscape in Canada prior to 2019. You can see that there were age and histotype restrictions imposed in certain provinces. But as a result of in part some of the advocacy work from the collaborative, since 2019, there's less inequity in the testing criteria across the country. So that all women with the personal history of ovarian cancer, irrespective of age, are eligible for genetic testing. There are still some differences between provinces with respect to the histotype that's eligible for testing, but nonetheless, it's more inclusive now than it was prior to 2019. It's important to recognize that BRCA1 and 2 aren't the only game in town. There are other genes that are associated with DNA repair that are known to be associated with an increased risk of ovarian cancer. If we look at what's in the germline, again, up to 20% of ovarian cancers are attributed to a hereditary predisposition. Most of those cases will be attributed to a BRCA1 or 2 mutation, but there are other genes, notably BRIP1, RAD51C and D, and mismatch repair genes that are associated with an increased risk of ovarian cancer. And so this table summarizes the lifetime risks associated with what we would call these moderately penetrant genes. The lifetime risk in the general population in the United States is estimated to be about 1.2% up to age 80. And you can see that the lifetime risks are elevated for those who inherit a mutation in BRIP1, RAD51C, and RAD51D. And because there is no effective screening test for ovarian cancer, the recommendation for these individuals who inherit one of these gene mutations is consideration of risk-reducing salpingo oophorectomy around the age of 50 to 55. Because BRCA is not the only gene mutation associated with an increased risk of ovarian cancer, it is important to cast a broad net when conducting genetic testing. And therefore, most jurisdictions would recommend panel-based testing, which would include BRCA as well as those moderately penetrant genes. There are challenges to genetic testing. Historically, this was the traditional model. A physician would have to initiate the referral for genetic testing. The patient would be referred to a genetic counselor. She would have her blood drawn and then meet again with a genetic counselor to go over test results. But we know that this can take anywhere from months to maybe even years. So there has to be a better way. Historically, there have been very low rates of genetic testing for patients with ovarian cancer, especially with that traditional model of referral. And a multitude of studies have documented that, including this one from JCO from the United States in 2017 that reported that only 10% of all eligible ovarian cancer patients had genetic testing. So overall, less than a third received genetic counseling and testing. It is well recognized that there is a shortage of genetic counselors across Canada and the United States. Again, this has been documented in many places. So there have to be strategies to improve genetic testing in ovarian cancer. So one of those strategies was implemented here in 2010 with reflex pathology statements. So in September of 2010, this statement was added to all high-grade serous carcinoma pathology reports. So basically the pathologist was reminding us to refer these patients to the hereditary cancer program. And as a result, genetic testing rates increased for these patients from somewhere around 20% up to 43%. Now, this study is a few years old. It was published by my colleague Gillian Hanley. We've done better than this, but just to illustrate that this was one of the early strategies to increase genetic testing rates in ovarian cancer patients. This was a process that was implemented by our colleagues in London, Ontario, called the opt-out process. So all women with newly diagnosed non-mucinous epithelial ovarian cancer were identified in an electronic medical record. And by default, they were automatically referred for genetic counseling and testing they had a 2 month period to opt out of this genetic counseling and referral process. But as a result, 94% of all eligible patients were actually referred for genetic counseling and testing. Virtual care would seem like quite an appealing process, especially in the context of a pandemic like this. So it may increase patient access, but it does not require or reduce the required genetic counseling resources, and it still does not yield a high uptake of genetic services. Group counseling, again, outside of the context of a pandemic, would seem to be appealing and increase the efficiency of the genetic testing, counseling and testing process, but it still requires 2 genetics appointments. Embedded genetic counseling model, bring the genetic counselor to the patient, particularly when they're undergoing chemotherapy, because they have a few hours at a time. So this has been described by in a few different centers. Again, it doesn't reduce the required genetic counseling resources. What about direct to consumer? So while this may be appealing and increase rapid access to genetic testing, buyer beware, there is the potential for false reassurance, particularly with one of these kits, 23andMe, which only tests for the 3 founder mutations associated with those of Ashkenazi Jewish heritage. So there is the potential for false negatives. A newer model is something called mainstreaming, which we've implemented here as what we call the GenOnc process. So this is referral directly from the oncologist or from the oncology clinic. And so with this process, we actually bypass the initial step with the genetic counselor and refer these patients for blood testing. And there can be 3 outcomes. If the blood testing reveals no genetic mutation or pathogenic variant, then no referral is needed to the genetic counselor. And that will represent the majority of cases. But if a pathogenic variant is found, the patient's referred to a genetic counselor. And if a variant of undetermined significance is identified, again, the patient is referred for genetic counseling. The problem with this is us, the oncologists. This is the rate limiting step. And I have to admit that we're not always the best to make these referrals. So we implemented a pilot program in BC called Genova, which was a central coordination of referrals to genetic testing, really led by a nurse navigator. And in this case, we were very fortunate to have Jennifer Santos as the nurse navigator for this program. The goal was to increase our hereditary cancer program referral rates from 40% to 80%. Patients were eligible if they had an invasive non-mucinous epithelial ovarian cancer, including fallopian tube, primary peritoneal, and sticks, excluding borderline and low malignant potential ovarian tumors, and patients with endometrial cancer, mismatch repair deficient on immunohistochemistry are also eligible. And finally, those with a family history of cancer that was suggestive of Lynch or BRCA but did not have mismatch repair testing, they would be eligible as well. And so in the 3-year pilot project, there were 464 women with endometrial or ovarian cancer. 381 were deemed eligible by hereditary cancer program criteria. 87% of them were referred to the hereditary cancer program for counseling and testing. Of the 13% who were not referred, 34 declined referral, and for 15, there was no response. And there were a number of patients who did not meet referral criteria. But in any case, this highlights the importance or the success of this central coordination process in which we were able to increase our referral rate from a historical rate of about 40% up to 87%. Now, where does tumor testing fit into all of this? Well, tumor testing will identify both germline and somatic mutations. So if you consider a hypothetical cohort of 100 individuals with ovarian cancer, and let's say they all undergo germline testing. Then that germline testing will identify 20 individuals with a germline BRCA mutation. But if those 100 ovarian cancer patients undergo tumor testing first, then 25 of them will have an abnormal result on tumor testing. And if confirmatory germline testing is done on those 25, that will help to identify those who have an inherited mutation versus those who have a somatic mutation. And the identification of both germline and somatic mutations is very important because of treatment that's now available for these individuals. That tumor testing will influence treatment, and we know now from the SOLO-1 trial, which randomized patients with BRCA mutations to a PARP inhibitor, olaparib, versus placebo as maintenance therapy. The initial results in 2018 demonstrated that there was a significant reduction in progression-free, or significant improvement in progression-free survival among those who had received olaparib versus placebo. So it was a 70% improvement. And the estimated difference in progression-free survival at this point was about 3 years. Now, these results were updated at the ESMO meeting last year, and you can see that the magnitude of benefit associated with olaparib is even greater. So a difference of 42 months is about 3.5 years. Now, this is unprecedented in the history of treatment of ovarian cancer. There's almost nothing that I can think of that has been shown to improve survival in ovarian cancer by 3.5 years compared to what the existing standard of care is. And so the patients who benefit are those with BRCA germline and somatic mutations. And so the genetic testing or tumor testing is extremely important to identify these patients so that they can benefit from this treatment. Now, we conducted a pilot study called Bonnie, which was really meant to validate our tumor testing infrastructure here in British Columbia. And so we had funding to test 100 cases. We actually started with 101, but there was only one case in which there was an insufficient sample for testing. And so we had 100 patients where the tumor was tested. There were 28 pathogenic variants identified, including BRCA1 and 2, and some of these other genes. In parallel, we did 100 germline tests. So all of those who underwent tumor testing underwent germline testing as well. And all of those pathogenic variants were identified. So in other words, all inherited mutations were identified by tumor testing, yielding 100% sensitivity. And so these results were just recently published by this large collaborative group here in British Columbia. Similar study was conducted by our colleagues in Toronto. They had 600 cases. They had a failure rate of 5%. 5%, there was insufficient tissue for analysis. But they had 570 cases that underwent tumor testing. 16% had a BRCA mutation identified. There were 200 paired germline and tumor tests, yielding a 19% rate of BRCA1 or 2 pathogenic variant identified, with 22 somatic and 16 germline. And they also found that their tumor testing identified all of the pathogenic variants in the germline. Now, tumor testing versus germline testing first, which is the optimal sequence of testing? So again, you take that hypothetical cohort of 100 women with ovarian cancer. If they all undergo genetic testing first, you identify 20 BRCA germline mutation carriers. 80 will be non-carriers. Those are the ones who will then undergo tumor testing to find the 5 or so patients who have that somatic mutation. On the other hand, if you start with tumor testing, 75 will be normal, but of those 25 who have an abnormal tumor test, they are referred for confirmatory germline testing to identify the 20 who have the germline mutation versus the 5 with somatic. So the first strategy, the top strategy, is actually what's recommended by ASCO in this publication from 2020. The second strategy, which starts with tumor testing, is what we're suggesting as the cost-effective strategy. And we presented this at ASCO this year. Just to summarize, we found that tumor testing first, followed by confirmatory germline testing, is the better strategy. It's less costly, which makes sense because fewer tests are done. We conducted a Monte Carlo simulation to estimate the outcomes of 10,000 ovarian cancer patients with high-grade serous carcinoma diagnosed in the United States every year. So with the ASCO strategy, there are far more number of cancer patients who undergo germline testing versus tumor testing first. But you can see that there's a comparable number of germline BRCA mutation carriers identified by either strategy. The National BRCA Collaborative published this position statement last year describing why tumor testing is needed for ovarian cancer in Canada. And we put forward 3 compelling reasons. Number 1, tumor testing will identify BRCA mutations, somatic BRCA mutations that would be missed by germline testing alone. The time to obtaining results from tumor testing is much shorter than it is for germline testing. And finally, tumor testing could actually improve the efficiency of the whole genetic referral process, translating into a higher number of BRCA mutations identified. Now, this genetic testing is very important because it will help to identify those who are at risk of developing cancer. But that cancer prevention journey is not always easy. The standard recommendation is risk-reducing bilateral salpingo oophorectomy, generally between the ages of 35 and 40 for BRCA1 mutation carriers, and a little bit later for BRCA2. And while this risk-reducing intervention is known to be very effective in reducing the risk of ovarian cancer as well as breast cancer, there are a number of adverse effects associated with this intervention. There are short-term adverse effects, such as vasomotor symptomatology, sleep disturbance, urogenital atrophy, sexual dysfunction, but also significant downstream health consequences, such as osteoporosis and coronary artery disease. And these have been shown in other large prospective cohort studies to potentially reduce life expectancy. So in 2013, we hypothesized and modeled this cost-effectiveness analysis, demonstrating that risk-reducing self-injectomy followed by delayed oophorectomy might actually be a better strategy than risk-reducing salpingo oophorectomy alone. We estimated or predicted that this 2-stage surgical strategy would improve quality-adjusted life expectancy compared to the standard of care. And I'd like to think that we planted the seed for 2 prospective studies that are ongoing, the TUBA and the WISP trial, which are designed to evaluate the long-term outcomes of this 2-stage surgical strategy. Now, many of those long-term health consequences, well, short and long-term consequences, can be mitigated by hormone replacement therapy. But we know that the uptake and compliance with hormone replacement therapy is not optimal. And so this large population-based study in British Columbia demonstrated that hormone replacement therapy use after early surgical menopause, after risk-reducing salpingo oophorectomy, was only about 50%. So clearly there's a need for increased or for better education for both healthcare providers and patients. I had the opportunity to work with these colleagues in conducting a population-based study of health outcomes after risk-reducing salpingo oophorectomy in BRCA mutation carriers. And this population-based study looked at cardiovascular disease and found an increased risk in these individuals, as well as bone disease, osteoporosis, and fractures. And so Helena Abreu-Deval is a master's student of Gillian Hanley. She had presented this as her master's thesis, which was successfully defended last week. And she's also published one paper on cardiovascular disease, and the other is in progress right now. And finally, to address the short and long-term consequences of early surgical menopause from risk-reducing surgery, we were able to implement a pilot survivorship program in Vancouver Coastal. So this gynecologic oncology survivorship clinic is championed by my colleague Lisa Dawson, and this provides counseling, education, and healthcare to individuals undergoing risk-reducing surgery who require ongoing advice and assistance relating to menopause management. And the clinic opened in March of this year, and the latest number of recruits is 82. So it's been a very successful project so far. So just to summarize, before I let Alicia take over, why is genetic testing in ovarian cancer so important? It's important for family members so that they can undergo risk-reducing interventions to avoid the diagnosis of cancer, but it's now also extremely important for personalized therapy. These individuals may be candidates for a PARP inhibitor, which has been shown to prolong their survival. So if you don't look for it, you won't find it. It's important to maximize uptake of genetic testing, and we've tried to do this with mainstreaming or our GenOnc process, central coordination of genetic referrals through our Genova program, and tumor testing, which we think will ultimately improve the efficiency of the whole genetic testing process. And this is a quote that Lisa Dawson often uses, but to identify a woman as a carrier only after she develops cancer is a failure of cancer prevention. And finally, it's important to recognize that there are significant health concerns after cancer prevention. So risk-reducing salpingo oophorectomy is not the end of the road for many of these individuals. And so with that, I'm happy to turn over the stage to my colleague Alicia. Thanks very much.
Okay, can everyone see my screen? Okay, so thank you very much. First off, again, thank you for inviting me, and I'm very happy to share the work we've been doing in the ovarian cancer space at Ovarian Cancer Canada and our partnerships with dedicated clinicians such as Dr. Kwon. So I laughed when I saw the quote by Lisa Dawson, because apparently we have the same taste in quotes. This is a quote that I show in every presentation about ovarian cancer prevention, as I think it perfectly captures what drives me personally and our collective work. So this is from a meeting in 2018. Every breast or ovarian cancer patient with a BRCA1 or BRCA2 mutation detected after diagnosis is a missed opportunity to prevent a cancer. No women with a mutation in BRCA1 or BRCA2 should die of breast or ovarian cancer. So clearly we are on the same page. So this has already been captured perfectly by Dr. Kwon, but I just want to further emphasize the importance of genetic testing in ovarian cancer and the impact both on those living with the disease and their family members. So especially related to family members, given my topic, detection of an inherited pathogenic mutation in an individual with ovarian cancer provides the opportunity for cascade testing in unaffected close family members and the use of very highly effective risk-reducing measures in those found to have a mutation. So really, genetic knowledge is power and allows the opportunity for prevention of a deadly disease. So at Ovarian Cancer Canada, our goal is to maximize prevention opportunities among 3 key groups. These include, firstly, relatives of those with ovarian cancer, and the work that is being done by Dr. Kwon and others is so important in this area, because really making sure that reflex, somatic, and germline testing is performed in as many ovarian cancer patients as possible, and they're then followed by cascade testing. There are also those that are at a high risk of a genetic mutation based on a family history. So we want to ensure that these women have timely and equitable access to genetic counseling and testing, risk-reducing surgery, and appropriate follow-up medical and supportive care. And finally, also covered by Dr. Kwon, those at average risk of ovarian cancer. So we want them to understand the options available to reduce their risk, including things such as opportunistic self-injectomy and oral contraceptives. So ultimately, we want to use a combination of data sources to identify gaps in opportunities for education and advocacy along the full continuum of preventative care. So to summarize our work to date, in the past year or so, we've surveyed 29 genetics clinics, and this was to really get real-world genetic testing practice data beyond the published guidelines. We also surveyed 12 gynae surgeons to start to collect real-world risk-reducing surgery practices, and I'll talk about how we're improving on this number now. We surveyed 42 previvors through an online survey, as well as conducted semi-structured interviews through Zoom with an additional 19 previvors. This led to an internal report on prevention and ultimately formation of a prevention task force to expand our work, which I will talk about more. So firstly, surveys and interviews with previvors or individuals with a mutation in BRCA1, BRCA2, or others who had not developed ovarian cancer, as well as genetic counselors and surgeons across Canada, revealed several regional differences along the pathway to prevention. So I just want to note, for instance, genetic testing criteria for women with ovarian cancer and unaffected relatives at the time that this work was conducted was varied greatly, as well as wait times for both genetic counseling and testing. There seemed to be unequal access to testing when there was not a known familial mutation. And the path for some patients in certain regions of Canada was very unclear. There were also differences in terms of who refers identified mutation carrier for risk-reducing surgery, as well as wait times for surgical consult and actually surgery. In addition, there was regional differences in the care of women found to have an isolated precancer lesion or a stick. So we also identified several systemic gaps. So actually a lot of systemic gaps. So just to go through these, there was really a lack of discussion on family history with family doctors. It seems that there were many not accessing counseling services, either pre or post test. There was also limited counseling on different elements, including the psychosocial impact of testing, communicating genetic testing results with family members, as well as the recovery process and side effects of risk-reducing surgery and options for post-surgical care. So one thing I struggled with when I was attempting to gain more information on the risk-reducing surgery practices is there's really a lack of readily available information on which surgeons are performing risk-reducing surgery outside of major centers. So this is something that I think really needs to be addressed, because I was thinking the whole time that if I was having such trouble, I could only imagine, a woman faced with this having even more trouble in a stressful period of time. Importantly, there's also few specialized clinics for risk-reducing surgery and menopausal management. And there definitely needs to be better adherence to age guidelines to maximize prevention. So I just want to highlight some of the gaps along this full pathway, first related to pre-test genetic counseling and genetic testing. So firstly, genetic testing criteria for unaffected relatives of ovarian cancer patients varied across genetic counseling clinics in Canada. So to highlight, one thing that was consistent was that all centers surveyed offered testing to an unaffected relative if there was already a confirmed pathogenic mutation in the family. However, testing based on predicted risk over here varied. So testing was offered to an unaffected relative based on predictive risk in most, but not all centers. However, the cutoffs used were different. So this could be based on less than 10% in 21% of centers and greater than or equal to 10% in 59% of centers. Based on my experience in the Prevent Ovarian Cancer program in Princess Margaret, I was wanting to know whether testing was automatically offered to an unaffected first-degree relative of a deceased high-grade serous ovarian cancer patient. And this was the case for 38% of centers. So it is noteworthy that genetic testing criteria in Ontario were recently updated. So as of September 2021, the threshold for testing of individuals with a family history, but no diagnosis of ovarian cancer has actually been reduced from 10% to 5% pre-test probability of a mutation. And this brings it in line with NCCN guidelines. In addition, all women diagnosed with invasive epithelial cancer, epithelial fallopian tube cancer, or peritoneal cancer at any age are now eligible, whereas previously it was not this wide open. And they've also identified a consensus list of 76 genes to be tested by all labs in Ontario, covering 40 cancer syndromes. So wait times for genetic counseling and testing of unaffected relatives definitely varied. So you can see that it kind of ranged from less than 6 months until greater than 2 years in 18% of centers surveyed. Within our surveys and semi-structured interviews with previvors, we asked if they were satisfied with explanations provided on several topics during pre-test genetic counseling. So I just want to point out the lowest level of satisfaction was seen for counseling on potential psychosocial impact of genetic testing. And also that 18% reported that they did not receive pre-test genetic counseling. In terms of post-test genetic counseling, the aspect that was not well explained according to our previvors was how to communicate your result to family members. The importance of this will become very evident in the next slide. And 15% claimed that they had not received any post-test genetic counseling. So the communication with family members is very important because, interestingly, 51% of previvors reported that it was actually a family member who first recommended that they pursue testing. And when asked whether they had previously discussed a family history of cancer with their family doctor prior to this process, 61% said no. So there's definitely a need for improvement here in communication of genetic testing results. So 2 themes emerged when asked for reasons for deciding to pursue genetic testing, and that was really having experience with ovarian cancer in a close family member at 42%, and the idea that genetic knowledge is power. So just to highlight a few, I saw what my mom went through and I didn't want that in my future. And then in terms of the genetic knowledge is power, burying my head in the sand wouldn't help. It was a no-brainer after I did my own research. So when asked about the psychosocial impact of learning their genetic testing results, this really varied, as you can see here. There were several who expressed a sense of urgency, anxiety, or shock, while a small proportion felt empowered to do something. I'll just read the first two as they perfectly encapsulate this. So I had a sense of urgency. I had never thought of cancer before, but then thought I had to do everything quickly. And it was a looming cloud, not if, it's when. So clearly there's a lot of stress at this period of time. So in terms of pre-surgical consultation and risk-reducing surgery, we first asked about referral to consult, wait times for referral to consult and consult to surgery. And this was from the clinicians that we surveyed. So 25% reported that there was a wait time of greater than 3 months to get from referral to a gynae surgeon to the consult. And then 42% had a wait of greater than 3 months to actually get to surgery. In terms of pre-surgical consultation, there were more issues that were not discussed to satisfaction. So these really were related to aftercare. So available options for hormonal treatments following surgery, options for reducing impact on bone and cardiovascular health. As Dr. Kwon mentioned, these are side effects of the surgical menopause. And available fertility or reproductive options following surgery, which was rarely discussed. So in terms of who performed the surgery, this is from our previvors and our surgeons actually. So 76% of the time it was a gynecologist or obstetrician. And 64% of the time it was ovaries and tubes. Although I take this one with a grain of salt, given the majority of this data was patient reported, and I don't have clinical data to support it. So one thing I'm very passionate about is making sure that women undergo this risk-reducing surgery according to the age guidelines, because as you know, the risk of cancer increases as the woman ages. And unfortunately, of those previvors that I spoke with, 43% of them had not maximized their opportunity for prevention. Either they had undergone surgery, but not by the recommended age, or they were already over the recommended age and had not yet undergone surgery. So there were a few reasons given why they had not yet undergone surgery. In many cases, genetic testing was only recently performed after a cancer diagnosis in a family member or themselves. Many had had a breast cancer diagnosis. Some of these women acted very quickly right after genetic testing, had their risk-reducing surgery shortly after learning their results. Others had not yet had risk-reducing surgery, either to just it only being a few weeks of knowing the information, but in addition, scheduling delays due to COVID. I'm not going to go through this in detail, but we highlighted one of these previvors in our report to the community. This is a woman who had asked for genetic testing for a long time, did not receive it. She was diagnosed with breast cancer and then discovered she had a BRCA mutation and has been delayed for her surgery based on COVID, and is feeling a huge sense of urgency there. So we asked them to reflect on their overall experience. And I'm not going to go through all of these quotes, but basically there was a lot of themes related to just not knowing information on how the surgery would impact them. So understanding the recovery process, the side effects, and how to manage the side effects is a huge gap, I felt, throughout these interviews. So to expand our impact, we've recruited clinical experts such as Dr. Kwon and Dr. Lisa Dawson, which all of you know, and then Dr. Michelle Jacobson, who's a menopause specialist at Women's College Hospital, and Dr. Sarah Keene from Winnipeg. And importantly, we went after these women because they are really leading the way for development of centers of excellence focused on the care of women at risk for ovarian cancer. So Janice has already talked about her clinic, and then there's a comparable clinic at Women's College run by Michelle Jacobson. And these are really models, I think, of centers of excellence for caring for these individuals. So we're currently working on several research collaborations with this task force, and I'm almost done, I see the time. These include interviewing women who've completed risk-reducing surgery through a specialized center. So we're starting at Women's College, but I'm excited to hear that you already have 82 women at your clinic. So I may start bugging you to put in an application there as well. We also want to better understand the risk-reducing surgery landscape in Canada. Obviously, I could only get a very small number of surgeons, so we are putting out comprehensive surgeries through SOGC to get the gynecologist feedback, and GOC to understand the practices of gyne-oncologists who do the surgery. We're also looking into establishment of a BRCA survivorship community of practice. And we really want to educate key clinical stakeholders who care for these women. And a common theme in this and our other studies, such as the Everwoman study, is that there's really a need to engage the family doctors, as they're a huge gateway to getting these women to genetic testing services as quickly as possible. So just very briefly, the work that we're doing, looking at the experience of previvors who have undergone risk-reducing surgery at a specialized center. So this is from our Women's College protocol. And we want to compare these with the experiences of women who underwent surgery at a non-specialized center, which is the bulk of those responses to date. And importantly, these findings may influence advocacy by Ovarian Cancer Canada for the development of additional specialized centers to really make sure that we provide the best care possible. And then this is just noting that we have surveys out on the risk-reducing surgery practices through SOGC, through Michelle Jacobson and GOC. So I just want to say thank you to all the previvors who generously shared their experiences through surveys and very in-depth interviews, as well as gynae surgeons and genetic counselors who participated in surveys. And then obviously all my collaborators and people who had helped us distribute the previvor outreach through Facebook and other means. So thank you.